So this is the one which we have left, and we'll go with the percussion. Okay, so percussion is going to be done in sitting posture. Okay, it should be done in sitting posture. Sitting posture. Okay, and supine posture for shifting dullness. Shifting dullness. Okay, so what are the areas you are going to percuss? Okay, so your percuss. There are two types of percussion. Okay, one is going to be direct percussion, which is done directly over the clavicle. And the second one is going to be indirect percussion. Okay, this indirect percussion should be done on anterior chest, okay, axilla, and three posterior chest. These are the areas of uh, percussion. Okay, so whenever you percuss, there are certain rules of percussion to be followed, which would have been told to you every now and then to you. Okay, so direction of percussion. Okay, always move from resonant area to non-resonant area. Okay, fleximeter is fleximeter. Fleximeter is the middle phalanx. Okay, this is called as fleximeter. Okay, fleximeter. Okay, and this fleximeter is the middle phalanx of the left or non-dominant hand, and it is firmly placed over the surface, and the other fingers are lifted off. Okay, and the next finger is going to be flexor. Okay, flexor. Okay, flexor. Okay, is the middle finger of the right or dominant hand. Okay, the movement of the flexor should be sudden and originating from the wrist, and the fleximeter should be kept parallel to the bottom of the area percussed and percuss over 2 to 3 times over each area. And percussion is always heard as well as felt. Okay, heard as well as felt. Always percuss identical areas. Okay, always percuss over the identical areas. This is called identical areas. So this is direct percussion, and this is the anterior chest percussion, lateral chest percussion, and posterior chest percussion. Okay, posterior chest percussion. Okay, and the distance between the fleximeter and the finger and the ear should be fairly maintained every time when you percuss. Okay, so these are few things which you have to go for it. Okay, so whenever you do the anterior percussion, okay, anterior percussion, always sit erect with the hands by the side. Posterior percussion, always you have to bend the head forward, okay, and keep the hand on the opposite shoulders. And lateral percussion, you have to keep the hand over the head. Okay, these things you should never forget. Okay, never forget. Okay, so this is very important thing in percussion. Okay, so usually the tip of the middle finger of the right hand strike the center of the middle phalanx of the left hand. Okay, that is very important thing to be noted. Okay, very important thing to be noted. Okay, so these are the areas of percussion which has to be maintained. Okay, so whenever you percuss over the percuss over the clavicle. Okay, whenever you percuss over the clavicle, okay, so you have to slightly stretch the skin. Okay, with one hand you have to slightly stretch the skin, and then you have to directly percuss over the clavicle. Okay, so this is the clavicle means you slightly stretch the skin below. Okay, you slightly stretch the skin below because you want to fix the clavicle. For that purpose, you slightly stretch and you directly percuss over the clavicle. Okay, so this is very important thing. Okay, very important thing. Okay, so this is very important thing for your examination. Okay, then next is whenever you percuss, you have certain percussion things to be always remember, and it will be asked in your exam. Okay, the first one is clavicle. Okay, where you are going to percuss over the medial 1/3 of clavicle. The second point is chronic isthmus. Chronic isthmus. Okay, so it is a band of resonance 5 to 7 centimeter over the supraclavicular fossa. Okay, so it is actually a band of resonance like this. Okay, it is bounded medially by scalenus muscle. Scalenus muscle. Okay, laterally by acromion process. Acromion process. Okay, anteriorly by clavicle and posteriorly by the patient trapezius muscle. Okay, the percussion should be done by standing behind the patient. Okay, and the resonance of the lung affixes assessed here. Okay, hyperresonance indicates emphysema. Okay, and impaired resonance indicate pulmonary tuberculosis or malignancy. Okay, malignancy. Okay, so this is very, very important. Okay. Malignancy will be impaired. Okay, so these are the things. Okay, so what are the qualities of percussion? Okay, qualities of the percussion. Okay, so whenever you percuss, okay, what are the different kinds of things you can get to see? Okay, the first is whenever you percuss, okay, the percussion note can be like this. Okay, normally the lung is resonant. Okay, normally the lung is resonant. Okay, the percussion note can be a tympanic note. Tympanic note. Okay, it is going to be tympanic note when you percuss over the hollow viscous. Okay, hollow viscous means abdomen. Okay, whenever you percuss over the colon, you are going to get tympanic note, and you can get subtympanic note. Subtympanic note. Okay, the subtympanic note is also called as cardiac resonance or box equality. Cardiac resonance or box equality, and usually you will get whenever you percuss above pleural effusion. Above pleural effusion, you get a cardiac resonance or subtympanic note. Okay, then next is hyperresonant. Hyperresonant you will get in pneumothorax. Okay, hyperresonant pneumothorax. So few people call it as dull, few people call it as impact. Okay, so how where you get what? Okay, so whenever you have impact note, impact, if you get over fibrosis. So impact if you get over fibrosis, and also a cavity surrounded by fibrosis. Cavity surrounding by fibrosis. Fibrosis. Okay, this is you get over impact note. Okay, and dull note you get over consolidation, collapse. Okay, and pleural thickening. So you remember as CCF. Okay, in consolidation and collapse you get a dull note. Okay, and fibrosis you get an impact note. Okay, impact note. Okay, impact is a better form of dull. Okay, dull. Okay, and where you get stony dullness, whenever you have pleural effusion, hemothorax, empyema. Okay, and even you can include pleural thickening. But classically, it is over the pleural effusion. Pleural effusion. Okay, so this is very, very important thing. Okay, then next is one more thing which they can ask you in your exam, which if you are good enough in answering, then they can ask you what is Guarino's method of auscultatory percussion. Guarino method of auscultatory percussion. So what is this? guarino method of auscultatory percussion. Okay, so you make the patient to sit. Okay, make the patient to sit. Okay, and examiner will go to the back of the patient. Okay, place the stethoscope in the last rib in the scapular line. Okay, so this is the scapular line. Okay, you place the stethoscope over here. You place the stethoscope over here. Okay, now percuss with the free hand. Okay, or uh, uh, somewhere like flicking. Okay, you can do like this. Okay, so along the three or more parallel lines from apex of each hemithorax perpendicularly downwards to note the dullness. Okay, so what you're going to do is you're going to percuss from here like this. So you note for the change in the quality of change in the note. Okay, that change in the quality of note, okay, is going to be seen over the Guarino's triangle. Okay, Guarino's triangle. Okay, and this Guarino's triangle area indicates that there is a localized pleural effusion over that area. Okay, it indicates that there is pleural effusion over the area. Pleural effusion over the area. Okay, so this is very, very important. Then one more thing, what they can ask you is what is crackpot resonance? Crackpot resonance. So crackpot resonance is usually, okay, whenever you take your hand like this, you apply oil. This sound is called crackpot resonance. Okay, and this is usually seen in large cavity communicating with bronchus. Communicating with bronchus. Large cavity communicating with bronchus. Okay, so this is the important thing. Okay, important thing. Then next is coming to the percussion method called as diaphragmatic excursion. Okay, diaphragmatic excursion. So what we call it as tidal percussion. Okay, tidal percussion. So what is this tidal percussion or diaphragmatic excursion? Okay, so whenever you have a patient, okay, so in the patient, what you're going to do is in the second intercostal space, you start percussing. Okay, percussing. Okay, you come down percussing like this, and usually in the fifth intercostal space, you get dullness. You get dullness. Now you tell the patient to inspire. Tell the patient to inspire. Okay, whenever you inspire, okay, wherever you got dullness in the same area, now what you're going to get is you're going to get a resonant tone. This means the lung is free. Okay. Whenever this resonant node disappears, okay, whenever this resonant node disappears, then it means that the patient is going to have something different there. Okay, something different there. So what is the something different we are going to get there? It is going to be either pleural effusion, pneumothorax, consolidation. Okay, so based on this, this is going to be the dullness which is going to persist is going to indicate patients having pleural effusion, pneumothorax, or consolidation. Okay, consolidation. These are very, very important things. Okay, very, very important things. Okay, very, very important things. Okay, so the fifth intercostal space is the one where you get the upper border of liver dullness. Okay, upper border of the liver dullness. Very, very, very important. This is called as tidal percussion. Okay, tidal percussion. Okay, so this is very, very important. They're going to ask you. Okay, so point of full expiration and full inspiration, and that is also called as diaphragmatic excursion. You can go down also and you can see for diaphragmatic excursion. Okay, so in the same point at the expiration, what is the note, and during inspiration, what is the note? Okay, and you can see the difference also. That is also called as diaphragmatic excursion. Okay, so this is very, very, very important thing for your exam. Okay, very, very important thing for exam. Then the next important thing, okay, for your exam is going to be your Traube space. Okay, Traube space. Any examiner is going to ask you on Traube space. Okay, Traube space. Okay, so any examiner is going to ask you on Traube space, and without studying Traube space, you should not go to exam. Okay, without studying Traube space, you should not go to the exam. Okay, what is this Traube space? Okay, always remember you have to be very sure about this. Okay, so what is Traube space? Okay, so what you're going to do is in the sixth costochondral junction, you draw a vertical line. Sixth costochondral junction. Okay, so if this is the sixth costochondral junction, draw a vertical line. Okay, then another line and the ninth rib along the mid axillary line. Mid axillary line along the ninth rib. This is ninth rib, mid axillary line. This is sixth rib along the costochondral junction. Okay, costochondral junction. Okay, now what you're going to do is in the sixth rib you're going to mark a point here. The ninth rib you're going to mark the point here, and this is the lower costal margin. Okay, this semilunar space is called as Traube space. Is called as Traube space. Okay, sixth rib, ninth rib. Okay, this semilunar space is called as Traube space. Sixth rib, ninth rib. Okay, so sixth rib, ninth rib. Okay, this is called as Traube space. Okay, so what are the boundaries of the Traube space? If you take the right side, it is the left lobe of liver. Left lobe of liver. If you take the left side, it is spleen. Spleen. Okay, if you take above, you see the lung resonance. Okay, lung resonance. If you take below, it is the left costal margin. Costal margin. And in between this area, okay, this is the stomach. So usually you will get a tympanic note on percussion. Okay, I told you whenever you have a hollow viscous, you get a tympanic note. So you get a tympanic note. Okay, whenever the Traube space is obliterated, okay, it should be something which should be filling the area. Okay, we should be filling that area. Okay, it should be pleural effusion, left sided pleural effusion. Okay, or it should be an enlarged spleen. Okay, splenomegaly. Okay, or enlarged left lobe of liver. Liver enlarged. Okay, or it should be a fundal growth. It should be a growth here. Okay, or it should be a massive pericardial effusion. Okay, so these are the things which are very important to note here. It can be a left-sided pleural effusion, splenomegaly, fundal growth in the stomach, or it can be a left lobe of the liver, or it can be effusion or pericardial effusion. Okay, pericardial effusion. So these are very important points to note here. Very important points to note here. Okay, so this is about our chronic systemus percussion is done standing behind the patient. Okay, and fibrosis in tidal percussion. Fibrosis in tidal percussion. Okay, so whenever you have fibrosis, again the same thing. Fibrosis, it will be shifted upwards. Okay, so instead of fifth intercostal space, you will get one space above. In fourth intercostal space itself, you will get dullness. Okay, you have to do it in the anterior surface also. You can do it in the anterior surface. Okay, but you can also do it in the posterior surface. Posterior surface. Okay, so whenever you have for example, amoebic liver abscess, what is going to happen? It is going to shift the liver upwards. Okay, so you get dullness over the fourth intercostal space itself. Okay, whereas emphysema, okay, what is going to happen in emphysema? It is going to be pushing the diaphragm down, so you can get in even in sixth intercostal space a tympanic node. Okay, and from here you can use this is also used to measure the liver span also. Okay, liver span also. Okay, liver span. Okay, liver span. So this is about the Traube space. Very important for your exam. Okay, very important for your exam. Okay, so this is Traube space. Okay, then shifting dullness you get in hydropneumothorax. Okay, and percussion tenderness you get over the empyema. Okay, empyema. Okay, so how will you demonstrate shifting dullness? Okay, so whenever whenever your lung is having shifting dullness, right? Okay, so how you are going to do shifting dullness? So whenever you have a lung which contains water and air. Okay, that is hydropneumothorax. You are going to get this. Okay, so what is going to happen is uh, whenever you demonstrate over the axilla, okay, in sitting posture, okay, sitting posture, you percuss, you get dullness. Okay, dullness. Now you tell the patient to lie down. Okay, on lie down. Okay, on healthy side. Okay, that is in the opposite side. What is going to happen? It is going to become resonant. So this is called as shifting dullness. Okay, when patient is sitting, they will be like this. When patient is lying down, what is going to happen? It is going to get shifted with water here and air here. Now when you percuss, you get a tympanic note. Okay, tympanic note. This is going to be or resonant note. Okay, so this is going to be what you get to see in shifting dullness. Okay, shifting dullness. Okay, shifting dullness is very important. Okay, shifting dullness is very important. Okay, so this is about our shifting dullness. They can ask you in exam where you get shifting dullness. Okay, then another one thing is hmm, so the first important thing here is going to be a shaped curve of Ellis. Okay, in patient with pleural effusion, whenever in patient with pleural effusion, if you mark the whenever it is a moderate pleural effusion, whenever you mark the whenever you mark the areas of dullness, okay, what you get to see is you get to see a S-shaped curve like this. Okay, this S-shaped curve is called as S-shaped curve of Ellis. Okay, S-shaped curve of Ellis. Okay, then next is you get to see Garland triangle. That also is asked by the examiners. Garland triangle. What is Garland triangle? Okay, so you go to the back of the patient. Okay, this is the spine of the patient. This is the spine of the patient. This is the spine of the patient. Okay, in spine of the patient, this is going to be there. Okay, so whenever there is going to be uh, pleural effusion, okay, pleural effusion, what is going to happen is just below the spine, okay, or near the spine, you get a triangle of dullness. Triangle of dullness. Okay, this triangle of dullness is going to be called as similar to our Broca's triangle. Okay, this triangle of dullness is called as Garland triangle. Okay, Garland triangle. This is also one thing which they can ask you. Okay, what is Garland's triangle? Okay, so this is going to be very important thing. Okay, a shaped Ellis curve. Okay, it is going to be few people tell it as a radiological illusion. Few people tell it as a due to point of maximum suction in the pleural effusion. Okay, so this again varies from version to version, but it is again very important for your exam. Okay, very important for your exam. Okay, so always compare with opposite side. Okay, always compare with opposite side. Coming to the last part of our discussion, which is going to be auscultation. Okay, auscultation. So auscultation of breath sounds. How you're going to do auscultation? Okay, it is going to be done in upright position in the front side with the patient sitting in back. Okay, patient leaning forward, crossed arms, leaning forward, nostrums. Okay. Then next is you can do in lying down posture also. Okay, but it depends how the patient is bedridden or not. Based on it, it is going to vary. Okay, very important thing. Okay, now coming to auscultation. Okay, not auscultation. So whenever you auscultate, okay, there are different areas of auscultation. Okay, auscultation. Okay, first is you have like this. Okay, so whenever you auscultate over the trachea, okay, whenever you auscultate over the trachea, what is going to happen is, okay, the sound will come to the trachea. If there will be a pause, and sound will leave the trachea. Okay, whenever you take this sound will be thick sound, thick sound. Okay, that is the tracheal sound. Okay, tracheal sound. Next is coming to the bronchus. Bronchus. Again, the sound will come to the bronchus. The sound will leave the bronchus. So you get a pause here. Pause here. Okay. But here, if you take the sound coming here will be very thick, and the sound leaving will be little thick. Okay, little thick. Okay. Then coming to the smaller airways, where you get vesicular breath sound. Okay, we get vesicular breath sound. Vesicular breath sound, you have, if you are going to take this as lung, okay, you divide the lung like this. Okay, after this area, okay, after this area, you are going to get vesicular breath sound. Okay, after this area, vesicular breath sound. The vesicular breath sound is usually here over this area. Okay, so here what is going to happen is the sound is going to come to the lung. Okay, and it is going to leave like this. Okay, so you get a like this. Okay, and there is no pause. This is the normal breath sound pattern you get to see. Okay, wait, you get to see. You get a upstroke, you get a downstroke. Okay, and there is a duration timing to be maintained. Thickness tells about the loudness or intensity. Okay, and the angle between the upstroke and the downstroke. Okay, so basically breath sound is heard in the most areas of the lung. Okay, and tracheal breath sound is going to be heard over the trachea, etc. Bronchial breath sounds usually heard over the up here hilum area, near the hilum area, and few people call it as bronchovesicular also. Okay, bronchovesicular also, it depends upon the thing. Okay, so this is about the important part of your respiration. Okay, respiration. Okay, so this vesicular breath sound is usually a high pitch sound. High pitch sound. Okay, so this is very important. Okay, and it is usually heard over the infraclavicular, axillary, and axillary, mammary, and interclavicular, infrascapular areas. Okay, infrascapular areas. Okay, so normally in the area, இந்த மார்க் பண்ணிருக்க ஏரியா எல்லாத்துலயுமே வந்து you will get vesicular breath sound. Okay, அதே தவிர மற்ற எல்லாமே bronchial breath sounds or tracheal breath sounds கிடைக்கும். Okay, and it turns out to be pathological. Okay, it turns out to be pathological whenever there is some kind of pathology. Okay, so what is those kind of pathologies which is very important for your exam? Okay, so whenever you have a patient lung like this, the airway is like this. Okay? And from there you are going to have smaller airways. Hello, hello, sorry. Good one. Okay, சரி, இப்போ ஒரு 6 யூனிட்ஸ் கொடுக்கேன். லூஸ் டூல்ஸ் இருக்குங்களா? லூஸ் டூல்ஸ் போகிறாங்களா? வாமிட்டிங் இல்லை இல்லையா? ஒரு கிரியாட் பண்ணிட்டு ரிப்பீட் பண்ணுங்க. யூரியா கிரியாட்டின். ஓகே, ஓகே, போடுங்க சிஸ்டர். என்எஸ்ஆர்எல் மாற்றி போட்டுக்கலாம். Okay, certain. So whenever you have a pathology here, okay, whenever you have a pathology over this area, I told in the half of the area where you get vesicular vessel, but imagine there is a pathology. Okay, for example, consolidation. Okay, then what is going to happen? The type of breath sound is going to change, and what the type of breath sound you are going to get is going to be called as bronchial breath sound. Okay, the same quality of the bronchial breath sound you're going to get here. Okay, so this bronchial breath sound is going to be of different types. The first one is called tubular breath sound. Tubular. Okay, so the tubular breath sound are high pitch sound. High pitch sound. Okay, so the usually what happens whenever the sound is getting transmitted. Okay, whenever the sound is getting transmitted, the intensity of the sound will decrease. The intensity of the sound will decrease. Okay, but here the intensity remains unchanged. Unchanged. Okay, that is going to be tubular breath sound. Okay, where you're going to get tubular breath sound. Okay, you get in PCP. Okay, so it is above pleural effusion. It is pericardial effusion. And the second here it is going to be C is going to be our consolidation. Consolidation. This is tubular breath sound. Next is we're going to have the next breath sound, which is going to be our amphoric breath sound. Amphoric breath sound again it's a controversial, but many books say that it is low pitch sound. Low pitch sound. Okay, and low pitch sound with high pitch overtones. It's a low pitch sound, but in between you get a high pitched overtones, which is of metallic quality. Okay, metallic quality, like how you see in robots and dogs talking movie, those kind of things. Okay, so it is going to be usually a cavity communicating with the bronchus. A cavity communicating with the bronchus. Okay, bronchus. Okay, or any air containing space uh, communicating with the lung. Okay, amphoric breath sound. And the next one, okay, next one is going to be cavernous breath sound. Cavernous breath sound. Okay, cavernous breath sound is a low pitch sound. Okay, it is usually seen in caves, that is cavity. Okay, if you want to assess a cavernous breath sound, you auscultate over the occipital area. Okay, occipital area என்ன sound கிடைக்குதோ அதாவது cavernous sound, or keep your hands like this and then that sound is going to be cavernous breath sound. Okay, that sound is going to be cavernous breath sound. Okay, cavernous breath sound. Okay, so this is very, very important. Okay, so these are the types of breath sound. Okay, types of breath sound. So where you will get diminished breath sound? Breath sound. Okay, so diminished breath sound can be due to anything. Okay, whenever there is a problem in the airway or in the lung. Okay, airway means it's going to be bronchial obstruction. Emphysema. Emphysema. Okay, lung in lung means it is going to be pleural effusion, pneumothorax, thick pleura. Apart from this, fibrosis of the lung. All these areas you get diminished breath sound. Okay, so airway problem irunda, then you can get diminished breath sound. Okay, bronchial obstruction, emphysema. Adhe lung la prachana irundhuchina, then you are going to get this kind of sound. Okay, this kind of sound. Then coming to the adventitious sound. Adventitious sounds. Okay, adventitious sounds. So what are the, this is what we were talking. Okay, coming to adventitious sound. Okay, so now coming to the adventitious sound. Okay, adventitious sounds. Okay, this is going to be adventitious sound. Okay, what is adventitious sound? Okay, these adventitious sounds can be continuous or it can be discontinuous. So you can classify this as continuous, discontinuous. Okay, this continuous can be high pitch, which is going to be our V's, or low pitch, the same variant of V's, which is going to be okay. Okay, discontinuous, Krebs, plural, Traube. Okay, so this is how they classify the adventitious sound. Okay, adventitious sound. Okay, so V's and Rauke. Okay, V's and Rauke. So V's is usually high pitch. This is low pitch. Okay, so this quality is going to be a hissing quality. Okay, hissing quality. That is called hissing quality, and this is going to be sibilant. Okay, here it is like a snoring, so it is called sonorous quality. Okay, so this is seen in, okay, this is seen in sister. No, box. Share sister. Say, okay, so okay. ஆனா வந்த கம்ப்ளைண்ட் என்னது? இல்ல என்ன கம்ப்ளைண்ட் தான் வந்தாங்க? சரி, யூரின் நான் ரிப்போர்ட் பார்த்துட்டு உங்களுக்கு கால் பண்றேன் சிஸ்டர். நான் பார்த்தேன். Okay. So small airway obstruction is you're going to get a this thing. Okay, but whenever so wrong way means it is usually when whenever your air passes through larger airways with obstruction. Okay, you can also divide this V's further. This V's further into monophonic V's, polyphonic V's. Okay, monophonic V's usually you will get in the obstruction. Polyphonic V's usually you get to see in asthma. Okay, asthma. Okay, so this is going to be monophonic V's or polyphonic V's. Okay, polyphonic V's. So these are few important things about your thing. Okay, then coming to the last part, which is going to be crepitation. Okay, crepitations. Crepitations are discontinuous sounds. Okay, non-musical sounds. Okay, whenever the crepitations occurs, it is due to bubbling of the air through secretions. Okay, these crepitations can be further classified into fine crepitations. Hello. No, sorry. Okay, so sorry. Okay, so here you are going to divide these crepitations into fine crepitations, coarse crepitations. Okay, fine crepitations, coarse crepitations. Fine crepitations is usually due to snap opening of smaller airways. Okay, small snap opening of smaller airways. Okay, it is usually seen in smaller airways, whereas coarse crepitations are usually seen in larger airways. Okay, coarse crepitations are seen in larger airways. Okay, so what are the causes of fine crepitations? Okay, fine crepitations. Usually, whenever they tell you fine crepitations, okay, fine crepitations, it is usually pulmonary edema, pulmonary edema. Okay, and you can also get to see, okay, that even in initial part of pulmonary edema, initial part of pulmonary edema, okay, and in initial part of pneumonia, early part of pneumonia. Okay, there you get fine crepitations. Okay, and this fine crepitations in pneumonia is also called as index crepitation. Index crepitation. Okay, whenever you have a coarse crepitation, okay, it is loud crepitations. Okay, it is usually seen in airway involvement. So it is seen in bronchiectasis. Bronchiectasis. It is also seen in pneumonia in the later part of pneumonia, and this is called as redox crepitation. Redox crepitation. Okay, and you also get crepitations in ILD, which is also a fine crepitation. Okay, and this crepitation is also called Velcro crepitations. Like Velcro, when you remove the Velcro, that kind of crepitation will be there. That is called as Velcro crepitations. Okay, so very important thing. Okay, then next is you can also divide in different way. Okay, early, middle, and late. Okay, in inspiration, you can divide it as early, middle, late. Okay, early means usually you'll get in bronchitis. Okay, bronchitis. Okay, then mid means you get in bronchiectasis, and late is ILD. Okay, so these are the different types of crepitations. Okay, bronchitis, bronchiectasis, ILD. Okay, so these are the different phases of crepitations. Okay, but just this is theoretical, but you cannot define it. Okay, then next is in bronchiectasis, you get the kind of crepitation which is called as coarse, leathery crepitations. Coarse, leathery crepitations. Okay, so this is very important thing for your exam. Coming to pleural rub. Okay, pleural rub. Okay, whenever you have an inflammation of the pleura, okay, then you are going to get pleural rub. Okay, so this pleural rub is here both during inspiration, expiration. Okay, and usually it disappears on holding breath. So any pleuritis, pleural inflammation will cause pleural rub. Okay, pleural rub. Okay, so this is about the important things about your different things. Okay, then the next important thing which is going to be very important. Okay, is going to be vocal resonance. Vocal resonance. Okay, how we are going to demonstrate vocal resonance? Okay, you keep the patient. I'll write it in a separate thing. Okay, so vocal resonance. Vocal resonance. Okay, vocal resonance. You make the patient sit. Okay, you place the stethoscope firmly on the chest wall and tell the patient to tell 111. Okay, or tell them to tell 99, 99, 99. Okay, better for our setup where they will not be able to tell 11 and all. So you I mean 99 and all. So you will going to tell the patient to tell 111. Okay, compare anteriorly, axilla, and posteriorly. Okay, so whenever what is this vocal resonance? Okay, vocal resonance is whenever the sound starts from the trachea, it goes and the intensity decreases. Intensity decreases. That is normal. But whenever you have a consolidation, okay, whenever you have a consolidation or a cavity, okay, what happens? This intensity is going to go unchanged. Okay, unchanged. Okay, so what are the causes? Okay, what are the causes where it goes unchanged? Whenever it is a solid media consolidation, okay, then it is increased. Okay, whenever it is a large cavity, it is going to be increased. Okay, so we know CCF, right? So we know dull note or impaired note is CCF. Then in that C is going to be increased. Okay, then decreased. Decreased in fibrosis, pleural effusion, pneumothorax. Whenever there is a media which separates the lung from the surface. So this is the one which separates the lung from the surface. Okay, so you are going to have a pleural effusion, for example. Okay, these things. Okay, and even you can include collapse. The quality lung is separated from the other area, that is going to get a decreased pressure. Okay, so this is very important thing. Okay, then next is there are certain variations. Okay, there are certain variations. The variations are going to be bronchophony. Okay, so bronchophony is actually what is happening here is the loudness and the clarity of the sound is here as if you're hearing over the bronchus. Okay, so the loudness increases, the clarity increases. This is called as bronchophony. Okay, and this is usually seen in consolidation. Consolidation. Next is egophony. Whenever the patient is going to tell you 91111, okay, or the patient is going to tell E, 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 it is going to be heard as A. Okay, normally E will be heard as E, but E, whenever we hear as A, this indicates consolidation. Consolidation. Okay, so as if someone is bronchophony and egophony, as if someone is talking from the diaphragm of the stethoscope. Okay, and the last one is going to be whispering pectoralochi. Okay, usually again in consolidation. Okay, whenever the patient tells one, 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 usually how you will hear is on, 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 because the sound gets dissipated. Okay, but now in consolidation, what is going to happen is there is no dissipation of the sound. Okay, whenever there is no dissipation of the sound, how the patient is going to hear is on, 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 on. Previously, how it was on, on, on. Now one, one, one. Now you can hear the syllable. Okay, clearly. Okay, that is going to be as if someone is whispering from the ear. Okay, that is called as whispering pectoral. Okay, whispering pectoral. Okay, so these are few important things which are very important for your exam. Okay, very important for your exam. This is about vocal resonance, and you should be very sure about this vocal resonance, and very importantly about these added sounds, which is going to be bronchophony, egophony, and whispering pectoral. Okay, definitely they are going to ask you the question in the exam. Okay, so question in the exam. Okay, so very important. Okay, if possible I will put you on sound. What is the sound? It is heard both during inspiration and expiration. What is this? What is this sound? This is your not audible. It should be audible. Why not audible? Okay, clear. This is actually plural rub. Actually, plural rub. Okay, plural rub. So if I have a ego phony sound, this is total Traube. Hello, hello. ஹாஸ்பிட்டலில் கொடுன்னு சொல்றேன், திருப்பி திருப்பி நீங்க என்ன கேட்குற? வீட்டுக்கு எத்தவங்க அப்படியே திரும்ப Can you hear something? When you keep the stethoscope also, that much sound only it will be here. No, you're not able to hear anything. Anyway, so this is egophony actually. Okay, the egophony, as I told you, it will be heard in that way only. Okay, in that way only. Okay, so egophony is because the sound E is felt as A. Okay, so this is seen in solid lung. Okay, solid lung. Okay, solid lung. So this is about very important about the plural rub. Okay, plural rub, bronchophony, egophony, whispering pectoralochi. Okay, whispering pectoralochi. Okay, and one more thing is tactile fremiters. Tactile fremiters is one whenever you keep the hand. Okay, the vibrations which are felt by the hand. Okay, as I yesterday also I told you, I think so. So here, if you see, there is going to be tactile vocal frequencies and vocal resonance. Okay, tactile is whatever you are going to feel over the fingers. Okay, feel over the fingers. Okay, so tactile from vocal frequencies. 1 second. One second. Okay, so tactile vocal frequencies is tactile means the whatever you are going to feel over the fingers. Okay, or the hand. Okay, vocal resonance. Two things are there. Okay, if you take consolidation, the tactile parameters is increased and vocal resonance is going to be increased. Okay, whereas in pleural effusion, tactile parameters will be decreased. Okay, so this is going to be the important thing. Okay, very important thing. Okay, so this is about our parameters. Okay. Okay, so this is about the important things about our so not audible. Okay, anyway, we will leave this. So this is very important about your thing. Okay, so this is one which you should be very careful. Okay, very careful in your exam. Okay, so this is what they will be asking you in your exam. Okay, and you should be able to answer this things in your exam. Okay, answer this in exam. Okay, so with this we are finishing our respiratory medicine. Okay, respiratory medicine. So as I told you, respiratory medicine, you are going to be very important for your exam. Okay, and you should be able to identify all these things in the exam. Okay, all these things in exam. Okay, and we are left over with our abdomen. So can we have it tomorrow morning 6:30 to 7:30 abdomen? Percussion not over cavity. Okay, cavity it is going to be increased. Okay, whenever it is a superficial cavity, it is going to be increased. Whenever it is a deep cavity, it is going to be dull or impact. I told you, no crackpot presence is increased. So can we have abdomen tomorrow? GI 1 hour tomorrow. Is it okay for you? Okay, so tomorrow morning we'll have abdomen examination. Okay, so tomorrow we will finish the whole thing about our discussion on clinical medicine. Okay, so see you all tomorrow. Okay, thank you. Bye.